Good afternoon, everyone. Welcome to our Thursday afternoon webinar. I'm so happy today. We have Dr. Koay from MD Anderson who's joining us. He's going to be talking about radiation therapy and molecular characterization of cholangiocarcinoma. Dr. Koay is an associate professor in the Department of GI Radiation Oncology at MD Anderson. He specializes in treating patients with hepatobiliary and pancreatic cancers, including cholangiocarcinoma. And his research focuses on how we can personalize therapy for patients with these cancers and the role that radiation therapy may play to improve outcomes. So Dr. Koay is going to go ahead and do his presentation, but I encourage and invite everyone to put questions in the chat that we can answer at the end of the presentation. So feel free throughout the presentation, if you come up with a question, just to type it in the chat and we will get to it at the end. All right, Dr. Koay, I'll turn it over to you, and thank you again for being here.
My pleasure. Thank you, Melinda. First of all, I want to thank everybody for taking time out of their day to join us for this webinar. And, for those who are watching after, the recording, I hope this will be informative and, will be, something that we can all learn from. I want to thank the Cholangiocarcinoma Foundation, also Melinda, especially for the opportunity. So as she said, I'm going to talk about radiation therapy. I'm a radiation oncologist. That's my clinical role, and I've been treating patients with cholangiocarcinoma for several years now. And it's an exciting time. There's a lot of molecular characterization, many targeted therapies that are coming out, and the role of radiation therapy in the context of this new molecular era is something that I'm going to try to touch on today. So this is the outline of my talk. We'll first touch on why do radiation at all for cholangiocarcinoma, and we'll primarily focus on intrahepatic cholangiocarcinoma. I'm happy to talk about extrahepatic cholangiocarcinoma as well, but today's talk is mainly focusing on intrahepatic cholangiocarcinoma. We'll speak about some of the technologies that are related to liver radiation, our recent results with high-dose radiation therapy for intrahepatic cholangio, and then go into some detail about our recent results that are looking at molecular profiles for patients with intrahepatic cholangiocarcinoma and in the context of radiation therapy specifically. And then we'll look to future directions and summarize. So first of all, why do radiation for cholangiocarcinoma? We are in a molecular era for this disease, and it's a very exciting time, as I mentioned, because we are now expanding treatment options for patients and, seeing responses, with these approaches. A sizable proportion of patients with intrahepatic cholangiocarcinoma have targetable alterations. It's estimated to be about 40% for patients with intrahepatic cholangiocarcinoma, which is much greater than other biliary tract cancers, which include extrahepatic cholangiocarcinoma and gallbladder cancer. Tissue and blood could be the sources to identify these mutations. So, a biopsy, directly from the tumor to look at the genetic profile of these things, or simply a blood draw. Those are ways that we can find these genetic alterations, and those could be used to help us direct the therapy for our patients. So the common things that we see are mutations in the IDH protein, IDH1 most commonly, but there's also IDH2. DNA damage repair proteins, those are other things that genes that are mutated commonly. FGFR alterations, most commonly fusions of a protein with the fibroblast growth factor receptor. Those are very common also with these patients. So we see mutations as well, so fusions as well as mutations in FGFR. So these are things that we look for, and the question, as we move forward with the advent of, these molecularly targeted agents for these different, subsets of, patients with these types of alterations, is what is, the role of radiation. And, I don't have a definitive answer for you today, but we'll speak to some of that, towards the end as we go through the presentation. But first of all, why do radiation therapy at all for cholangiocarcinoma? And in our view, what we try to understand is what is it that ultimately gets patients? What is the lethal cause? The reason, the cause of death for patients with, cholangiocarcinoma. And this actually does apply for both intrahepatic and extrahepatic. This particular subset of patients, 79 consecutive patients, was specifically for intrahepatic cholangiocarcinoma, but we've also actually published some data similarly for extrahepatic cholangiocarcinoma and saw similar. And the basic take-home point here is that the vast majority of patients are dying of biliary complications or vascular complications within the liver, or a combination of the two, combination of both biliary and vascular complications. This is over 2/3 of patients are dying of things in the liver, from the tumor directly. The biliary complications can be either mechanical or just direct invasion of the tumor into the biliary tract. And what that ends up doing is blocking the outflow of bile from the liver to the digestive tract. The bile is the juice. It's something that helps you to digest your food. And if it's blocked and it can't get out of the liver and is stuck there, the bacteria that populate the bile duct tree can eventually lead to an overwhelming infection, sepsis, that can be lethal. So that biliary complication is quite common for patients, as we saw in these 79 patients. But there's also vascular complications. These vascular complications, again, could be direct invasion of the tumor or mechanical compression, very similar to the biliary complications. In both situations, the bile duct as well as the blood vessels, those are just hollow tubes, and they are conduits for these fluids to go through. So if either one of them, the blood vessels or the bile duct tract, gets compromised either mechanically or because the tumor directly invades into those tubes, that can be a lethal consequence for our patients. So we saw this quite commonly in these 79 patients over a course of about 15 years or so at MD Anderson. These were all patients with unresectable intrahepatic cholangiocarcinoma. And this is the reason that radiation may help, conceivably. Okay, and other local modalities that can include Y90 or other types of, things that you direct at the liver. If you can achieve control of those tumors, what we call local control, where the tumor originated in the liver, and we can control that from spreading or growing, that could translate into a benefit in terms of overall survival, how long our patients are living after the treatment. So this is the reason why we are advocating for radiation therapy at MD Anderson as well as other places, or other local modalities for the liver, something that's personalized for the patient's situation. And we've published on how we might choose this, and this is for patients who are non-surgical and have different options for liver-directed therapies. There's a large array of liver-directed therapies that are available to patients these days, and that list is ever growing. So this is just a sampling of what is currently available, but it's certainly not comprehensive. So we look at the anatomy of the tumor. Where is it in relation to all the other structures around the liver? So this is a picture of the liver in the body, and then this circle is the tumor. And we also look at the characteristics of the tumor. How vascular is it? Is it fed by blood vessels such that we can inject chemotherapy or things like Y90, yttrium-90, into the tumor successfully? Or are they hypovascular, meaning that they don't have a very good blood supply, and if you inject something, it's really that drug or that therapy is not really going to reach the cancer cells, and so it's not going to be very efficacious. So those are two different things that we look at as physicians to try to decide what is the right thing for the given patient that we have in front of us. Anatomically favorable, again, is related to where that tumor is in relation to such as the bowel, the stomach, the gallbladder, the common bile duct, the kidneys, the heart, the lungs. All of those things kind of surround the liver. And we have to take that into consideration whenever we're considering a patient for things such as external beam radiation, percutaneous ablation, where we stick a probe into the tumor and try to ablate it either thermally or with microwaves. So these are the considerations, and what we've listed out here are some of the possibilities whenever you have these kind of combinations of different things. So if the tumor is anatomically favorable and has a low vascularity, the two options that we think would be very reasonable in that case are external beam radiation and percutaneous ablation if the tumor is small enough for ablation. Typically the size cutoff is 4 centimeters for that. Okay. With external beam radiation, we actually can radiate anything as small as 1 centimeter or so, or as large as over 25 centimeters. We have quite a range of efficacy whenever we talk about external beam radiation. Now, if the tumor is anatomically favorable, so it's away from the bowel, it's away from the kidneys, the heart, and lungs, you actually have quite a lot of different options, especially whenever they are hypervascular, meaning that there's a lot of blood vessels feeding that tumor. So external beam radiation is still an option. Percutaneous ablation is still an option. This is where Y90 and TACE, so transarterial chemoembolization, those are now things that the interventional radiologist could offer and hopefully successfully treat the tumor with. Now, if the tumor is unfavorable anatomically and has a low blood vessel arterial blood supply, then the real main option there is external beam radiation. Perhaps percutaneous ablation in some sense, but usually the ablation is also limited by whether there's large blood vessels nearby the tumor, because if they're using heat to try to kill those cancer cells, those blood vessels that are flowing by that tumor are going to act as a heat sink, meaning that it's taking away the heat that you're using to try to cook that tumor away from that area, and that's causing the tumor to not be cooked evenly, and so it may not be an effective ablation. So this is why external beam is the main thing in this particular situation. Now, if the tumor is anatomically unfavorable and hypervascular, Y90 and TACE now again come back into play. So these are some of the general considerations. There's many other considerations that I'll touch on in a couple of slides, but this is kind of how we generally begin thinking about how we assign or offer different therapies that are liver directed for a patient with intrahepatic cholangiocarcinoma or a liver metastasis, for example. And one of the other things that factors into our decision-making, especially whenever it comes to external beam radiation, is something called radiation-induced liver disease. RILD is the abbreviation that we commonly use. This is irreversible damage from the radiation therapy to the normal liver. There's actually an analogous type of side effect from radioembolization with Y90. Is called Y90 induced liver disease. So these are things that are known side effects, and they're irreversible. So that means that we can't take it back if it happens. So we have to be very careful about how we approach patients about the therapies that we can offer to them, because if it does happen, supportive care is all that can be done. This can be quite a devastating side effect, both as a physician and then also obviously for the patient and the family. So we try to avoid getting into the situation as much as possible. We factor in multiple things, and what really drives those decisions is the underlying liver function of the patient. We look at the liver function tests that include things like the albumin, the bilirubin, and so forth. Those help us to see how functional the liver is, before we start the radiation. We also consider other comorbid conditions. So things like whether you have cirrhosis, whether you have other medical conditions, and I'll touch on those in a couple of slides. But those are the factors that predispose patients to be at higher risk of developing this, devastating side effect. So we factor all those things in, whenever we're going in to see the patients for consultation, so that we can advise them, this is what we think your risk is of developing this, this potential side effect. But if all things are otherwise equal and, the patient has a low risk of developing this, we still go to, quite a extensive, list of lengths of, treatment and technologies to ensure that the risk of this is as low as possible. So how do we achieve that with technology, to try to avoid that devastating, side effect of radiation-induced liver disease? The the technologies, as I explain it to my patients, is that we combine, these, very innovative, groups of different types of technologies, as highly conformal therapy. That can be in the form of intensity modulated radiation therapy. Protons is another type of radiation therapy that we can offer. And then stereotactic radiation is another form of radiation delivery technique that we can offer in some situations. The liver is right below the diaphragm. And so whenever you're breathing and you're on the radiation treatment table, your diaphragm is moving that liver up and down if you're breathing while the radiation beam is on. And so if this is the tumor volume here, and this is where my dose cloud of radiation has to encompass, I have to make sure that the tumor, as it moves up and down, is encompassed by that dose cloud. Otherwise, I'm going to miss the tumor if it's outside of the dose cloud. So respiratory management is one of the key things that we have to incorporate and consider whenever we're delivering the radiation therapy. We can achieve this respiratory management in a couple of ways. One of them is simply recording the up and down motion of the tumor while you're breathing. The other way is to actually have you hold your breath for about 10 to 15 seconds at a time so that the tumor is stationary whenever the radiation beam is on. And that allows me to reduce the size of my radiation field and cover that with much tighter margins, because now I have a stationary object that I'm trying to irradiate. So that respiratory management is one of the key things that helps us to avoid any excess radiation, along with this highly conformal therapy. Now, in addition to these two technologies, we need to be assured that we're hitting the right spot every day before we turn on the radiation beam. Radiation is typically given anywhere between 4 to 30 treatments. Typically, at our institution, our favorite regimen is 15 fractions, because that gives you, a good flexibility in terms of delivering a moderate dose to the tumor and the surrounding normal tissues cumulatively to build up to a very high dose of radiation. But during the course of those 15 treatments, 3 weeks of treatment on average, for our patients, we have to be assured that the patient's in the same position on a day-to-day basis. And so this is what the onboard imaging helps us to achieve. We have an image guidance system that's integrated with our linear accelerators that deliver the radiation, so that we can be assured that the patient's in the same position and that the tumor is in the right location in the path of those radiation beams so that we hit the right target. We'll also talk a little bit towards the end about some functional imaging and some quantitative imaging that we could use, perhaps in the future. So these are all the technologies that we incorporate. The three common ones that we use on a day-to-day basis are these highly conformal types of radiation delivery, the respiratory management, and the onboard imaging. So I'll just show you a little bit of some examples of what that looks like. So this is what a CT scanner and simulation looks like for a patient. We use a cradle that's customized to your body to immobilize the torso and the arms so that the arms are out of the way of the radiation. The liver would be in this area here. And we place an infrared reflector on the abdomen of the patient, and that's tracked on the other side of the table with an infrared camera. So as the patient's breathing, we can see that reflector moving up and down on the abdomen. And what we do is we give the patients a visual feedback to see where we need them to hold his or her breath. Okay, so we give them a target for the breath hold, and they're seeing the movement of this bar going up and down as they're breathing, and they'll hear over an intercom, "Please hold your breath," and they'll bring that bar into the target area and hold it there for about 10 to 15 seconds. We acquire the images, and we're done with the simulation with about 45 minutes to an hour. And then we use those images to plan out the radiation. And this is essentially the same setup as we have in the actual linear accelerator room. You can see this little cabinet here that has a laser, and you can see a little green laser beam actually on this side. We use that to localize, and kind of triangulate all of the body into the right position within the simulation room and translate that coordinate system over to the linear accelerator room where the therapy is actually delivered once the patient starts. You can see marks on the patient's body, you can see marks on the cradle. Those are all things that we just use to, double and triple check to make sure that the patient's in the right position, the tumor's in the right position in the path of the radiation beam, and that what we plan is what we actually deliver once we start the radiation. So these are all the parts of the setup that are critical to make sure that we deliver this safely. And again, all of this is to try to avoid major side effects like the radiation-induced liver disease, along with side effects with regards to the bowel and the stomach and the heart. So this immobilization and the motion management are things that we try to achieve during the simulation. There are other ways to immobilize and minimize the motion due to breathing. There's something called abdominal compression. There's other surface guidance technologies that other institutions are using these days. This is just the way that MD Anderson has set it up, but there's many other ways to try to approach this. So whenever we get started with the treatment planning process, we acquire that CT scan in the treatment position, as I just showed you on the previous scan, and we model that radiation dose. And the way that we model it is by calculating the density of the tissues. We know based on physics and math, how the dose accumulates as the radiation beam is angled and pointed at the tumor and going through all these tissues. And what that gives the radiation oncologists, like me, is a dose distribution. And I can see, what kind of doses are getting to the tumor and what we can expect to get as far as doses to critical organs such as the stomach and maybe a little bit lower, the large bowel and small bowel. So we call this approach a simultaneous integrated boost with simultaneous integrated protection. This was something that Rhonda Tao and Chris Crane, one of my mentors, published in JCO, one of our top oncology journals, back in 2015. And this has been a decades-long experience of radiation treatments. Those 79 patients that I mentioned earlier, and why we do radiation for patients. And it's because we've seen that they die of tumor-related liver failure because of vascular or biliary complications. And so what Dr. Crane and others, pioneered was the delivery of really high doses, 75 gray to 100 gray in 25 fractions to tumors large like this one, whenever they're in very close proximity to organs at risk like the stomach. We have to give a safe dose of radiation to the stomach, because 100 gray and 75 gray are both way too high for the stomach, outlined here in the kind of gold color here. So what we do is we create a buffer zone, what we call a planning risk volume, so that that high dose region does not go into that area. And there's a dose fall off to a dose of 45 gray that is safe for the stomach. We routinely treat the stomach with patients with gastric cancer, for example, with this dose, and it's safe, as well as showing some efficacy. But that dose beyond around 50 to 55 gray is considered to be kind of the threshold that if we go beyond that, you could get some toxicity whenever it comes to your stomach in terms of ulcers or bleeding events. You might also notice that these radiation dose lines, we call these isodose lines, that they're not uniform, they're not circular. And the reason is because we're trying to curve that radiation so that we avoid any excess dose to the healthy normal tissues. We have to get that dose in, and so our physics and dosimetry teams will design these so that we can minimize that exposure of high doses of radiation and even low doses of radiation to the healthy tissues, including the normal liver. So this is why this looks so complex, but there's a lot of thought that goes into it, and many calculations and other teams that work behind the scenes to take care of our patients. Now, I mentioned both protons as well as IMRT. These are both ways or tools that we have at our disposal to deliver these high doses of radiation to the liver. And the main difference is how these different types of radiation deliver that dose. you can see with this dose paints, these are, 1-to-1 in terms of what the dose represents. So the red is, the highest dose, and the blue is a lower dose, that's safe for the bowel, for example. And you can see that whenever we use protons, the beam and the low dose area stops after a certain depth of tissue. So this is quite advantageous whenever you have tumors that are mostly right-sided or perhaps even central. You can use protons for patients who have left-sided tumors. This is a CT scan, so we're looking upward, and this is the right side of the patient's body. But for central tumors and large ones like this that are, surrounded by the stomach and, the large bowel here, IMRT is another way of delivering this radiation, but you can see that there's a low dose scatter, because these X-rays, or also called photons, do not have that property of stopping after they've gone through a prescribed depth of tissue. They just keep on traveling through the body. So there's advantages and disadvantages in these situations. IMRT in this particular situation allows us to have a better control of the high dose regions and better coverage of this massive tumor, so that we get better coverage and avoid the high doses to these critical structures like the large bowel and the stomach here. Whereas, with protons, especially for right-sided tumors, you can blast away, and usually there's not very much in terms of, critical structures, except for maybe large bowel if the tumor comes down below. So these are some of the considerations that factor into our mind whenever we're thinking about whether to use protons or IMRT for a given patient. It's really this dose distribution, the favorability of the anatomy, as well as, how the patient sets up whenever we do the simulation. So this is what it looks like whenever we have, the image guidance. We use a CT on rails. There's other ways to approach this. You can use something called Conebeam CT. That's another way to obtain three-dimensional information about the internal anatomy and see the actual target and make sure that your target is being hit by the radiation beam on a day-to-day basis. In this particular example, this is what the table looks like whenever you're on the treatment table. And in this particular technology room, we have the ability to swing this patient couch from one side of the room 180 degrees to the other side of the room where the linear accelerator is. So the first step is to swing the patient over in the treatment position and have the CT on rails move across that patient so that we can image the abdomen and the liver. And then once we verify that the patient's in the correct position, that the tumor, is similar and the internal anatomy is similar to what we originally planned, then we swing the patient over to the other side and, we begin the delivery of the radiation. If we find that the internal anatomy is slightly different from what we had planned, we actually have the capability to adjust on the fly and, make shifts so that we avoid any high doses of radiation to critical structures like the small bowel, the large bowel, and the stomach. So this is one of the technologies that really helps us to ensure that we are delivering the radiation safely. And again, trying to avoid some of the devastating side effects that radiation could have otherwise. This is an example of a patient that I treated with high doses of radiation for a very large right-sided tumor. We're able to superimpose those Isodose lines. And we simplified this one because we're primarily interested in the doses that are critical for both the liver and the bowel, the stomach, the heart, for example. And so those are the ones that we pay attention to the most. And we make sure that it's covering the areas that we need to. This is where the tumor is. And we're avoiding any of this high dose area to things such as the esophagus right here, or the stomach, which would be over here. Same thing happens with the bowel. We're looking at, all these other images. This is a front view of the patient, kind of looking at them face on. And we can see that dose distribution, the Isodose line, in regards to the rest of the bowel down below and, the stomach. So this is how we evaluate before we turn on the radiation beam on a day-to-day basis, to have absolute, confidence that we're delivering this as safely as possible. At our Proton Center, we currently don't have the 3D image guidance. And so we have to use something as a surrogate for the anatomy. And, the medical term for that is a fiducial. So a fiducial is something that a metal or a radio opaque substance that you can implant directly around the tumor, what we call peritumorally, so that we can visualize this on an X-ray. So this is an X-ray that we have at the Proton Center, and we're able to visualize these fiducials. They're very small little, radio opaque markers that you can see within these things on the film. And we take both side as well as front to back images so that we can be assured that those fiducials are in a very similar position as they were whenever we did the original planning. And we can visualize also what that radiation dose distribution looks like, whenever we do these things. So this is the other way of doing the image guidance. You can use a surrogate of that and just make sure that whenever you're planning it, that those dose lines, those isodose lines, are not going into the critical structures like the bowel whenever you align to these fiducial markers. So that's the other way of doing the image guidance. So I touched on some of the clinical factors in determining the eligibility for radiation therapy, and we'll just kind of rehash those really quickly here. Those include the baseline liver function. So what do the labs, for the liver function tests look like? Again, the most critical ones are the bilirubin, the albumin, and a few others, which include something called the prothrombin time and the INR. Those are functional readouts of your liver function. We also look to see whether you have ascites or fluid within your abdomen that's accumulated because it's not efficiently going through the liver system itself. And then also whether there's any confusion because the liver is not functionally processing the ammonia levels in your body. That can be another sign and indication that the liver is not functioning very well, and that radiation-induced liver disease might be a hazard for a given patient. So this baseline liver function is one of the keys, in determining eligibility for radiation. The patient's performance status is also something that weighs on my mind, whenever I'm evaluating a patient. And the question is, how functional is that patient? Are they sleeping all day versus are they going out and walking and very functional and around the house, for example. We have to also consider whether the patients received any prior liver-directed therapies, including external beam radiation. Y90 is another liver-directed therapy that exposes the healthy tissue to radiation. There's others that could also be factored into this. That can include surgery, ablations. There's cryotherapy these days. There's TACE. Many things that could be happening, with the liver, that we have to consider whenever we think about whether the liver is functionally capable or, healthy enough to, receive external beam radiation. And then finally, other medical conditions, whether the cirrhosis, primary sclerosing cholangitis, primary biliary cirrhosis, collagen vascular disease, ulcerative colitis. These are all of the things that we try to factor into the history taking whenever we meet with a patient. Once we decide to go forward with the radiation, how does that look? And what I often quote our patients is that we've seen evidence to suggest that the radiation is helping to prolong the survival time of the ones who receive this high doses of radiation, what we call ablative radiation therapy. And we published this again several years ago in JCO, and this was the 79 patients that we treated over a course of about 15 years at MD Anderson. And in the middle of those 15 years or so, around 2007, we adopted that CT on rails technology. And that's what gave us confidence that we could start escalating the radiation dose safely. Once we started doing that, we started seeing patients living, substantially longer and having better control rates compared to the previous era, where we were giving lower doses of radiation. This is BED stands for biologically equivalent dose. So whenever that dose was less than 80.5 gray versus greater than 80.5 gray, we saw a substantial difference in terms of the local control, whether we were able to stop that tumor from growing or not, and then also the overall survival. And the dose of the radiation in this particular retrospective study was the single most important factor that predicted both the local control and the overall survival outcomes of the patients. the vast majority of these patients got some sort of gemcitabine-based chemotherapy prior to coming to us for radiation. We also looked at this in collaboration with colleagues from University of Pennsylvania, as well as from Massachusetts General Hospital, MGH. And we did this study for both patients with intrahepatic cholangiocarcinoma and hepatocellular carcinoma, HCC. So the cholangiocarcinoma patients their outcomes are listed below. This was using the 15 fraction proton radiation regimen. We saw a 2-year local control rate of 94%, and then a 2-year overall survival rate of 47%. These were all patients who were not eligible for surgery. These were all patients who came to us and received definitive radiation therapy to either 58.05 gray in 15 fractions or 67.5 gray in 15 fractions. The dose of the radiation was decided whether the tumor was centrally located near the bile ducts as well as all the blood vessels of the liver versus peripherally located away from that central area where all those critical highways are. So those were the doses that we prescribed for these patients, and these results were quite unprecedented. So very excited, and led to some clinical trials subsequently. This is a patient that I treated several years ago. She was 66 years old and presented to us with a very large liver lesion. It was staged as T2N2 by AJCC stage, AJCC edition 7. And the biopsy showed high-grade intrahepatic cholangiocarcinoma. The original tumor measured 10 centimeters in dimension, so this was quite large, and it invaded into 2 of the major veins of the liver. So the hepatic vein is one of the blood vessels that helps to return the blood from the abdomen back to the heart, and then the portal vein is the vein that returns the digested nutrients from the abdomen, all the gut, back to the liver so that it can be processed, and then that energy is either released or stored or returned to the heart. So invasion of these 2 things is what led to this fluid accumulation around the liver. So this is all ascites, this kind of intermediate gray color. This black is what it should look like. This is fat. This liver should be surrounded by this, dark, fat, density, but it was surrounded by ascites because the fluid was not returning efficiently back to the heart because of the way that this tumor is invading. Here's another slice, a little bit, at a different level. So I treated her with protons. We treated to a total dose of 67.5 gray and 15 fractions. We met her dose constraints. So we were trying to achieve an average or mean liver dose below 24 gray, and also spare a certain volume of liver. So 700 cc's below that critical threshold of 24 gray. So whenever we have used those dose constraints, we have observed, basically no liver-related side effects. So this is a very safe dose as long as you can achieve these types of liver constraints with your radiation treatment plan. And in follow-up, she developed a very nice response. The tumor, in terms of size, actually didn't shrink immediately. It actually eventually shrunk to just a few centimeters in size over the course of several years. But in her first follow-up imaging, this is what it looked like. Much of the tumor, just kind of melted away, in contrast to what it looked like before. All this fluffy stuff in the middle of this scan is tumor, viable tumor. And so what ended up happening after the radiation is that it just became kind of this fluid-filled ball that slowly over time, began to reabsorb. We consider success in this particular situation as the tumor either shrinking or just staying the same size. As long as the tumor does not grow, we've considered ourselves to be successful with the delivery of the radiation. She did develop some side effects in terms of some abscesses and then, a biliary stricture, which happened right here. This is her bile duct that was blocked because of the stricture. But we were able to manage that and, get a stent in there. And, she actually survived for several years after receiving the protons, when otherwise her life expectancy was just a few months otherwise. So we really feel like we made a difference here. And, this is the type of results that we've seen in other patients as well in similar situations. So we've seen what radiation, just for all comers, patients with intrahepatic cholangiocarcinoma, after chemotherapy, whether with response or no response, what we can achieve with these high doses of radiation using these technologies. But now, as we're going into the molecular profiles and looking at these genetic alterations that I mentioned at the very beginning, how does radiation play into that, and what are the results that we're seeing? So we've since expanded our treatment of patients with unresectable intrahepatic cholangiocarcinoma over these past few years, and particularly again after 2007, we started giving these higher doses, and so we focused on the patients who received these ablative radiation doses above the BED of 80.5 gray, and that totaled a number of 156 patients up till 2020. 114, the majority of the patients had next generation sequencing done. And the median age of these patients was 66 years with a range of 31 to 89 years. The median number of tumors was 1 with a range of 1 to 5. Over half of the patients in this study population had satellite lesions, so they had more than 1 tumor. And then 73% had IMRT with X-rays or photons. And then the other proportion of patients had protons, 27%. We gave a median dose of 67.5 gray in 15 fractions with a range of 58.05 to 100 gray in 10 to 28 fractions. I've had a number of students work on this particular project. The results showed that after radiation therapy, the median survival was 21 months. It was actually in the 30 month range overall whenever you factor in chemotherapy. So very respectable survival rates for patients with unresectable intrahepatic cholangiocarcinoma. As I mentioned, we kind of expanded the indications for delivering radiation after that JCO publication, as well as the Proton publication subsequently. And in that study, we had a 2-year local control rate of around 94%. Here, because we're expanding that indication and taking some patients who are less favorable and also have much more disease burden, our local control rate in this particular study was 81% with a range of 72 to 87%. Now, among the patients who had no metastases outside of the liver at the time of radiation, that was 111 of these patients. 40% of them developed new metastases within a year. So the radiation is not necessarily curing, these patients, unfortunately. By itself, it's not going to necessarily control all the disease that the patient has, but it can still prolong survival. And I think one of the points is that if you can achieve that local control and prevent the tumor-related liver failure, there still may be a benefit even if the patient develops new metastases, whether within the liver or outside of it. In this study, we also saw common mutations in terms of IDH1, TP53, ARID1A, FGFR, BAP1A, and IDH2. There were no somatic mutations that were identified in about 14% of the patients. For those of you who are really fast at math, some of these patients had multiple mutations, and so there's overlap in some of these groups. That's why this number adds up to greater than 100%. So we're just looking at whether the patients had a mutation in this or not, but not looking at combinations. So what were the radiation outcomes? Whenever we give these really high doses of radiation, what were the survival rates 1 year after radiation, as well as local control rates after 1 year radiation? In patients who had a mutation in IDH1, for example, versus wild type. So you can see that the wild type group, was around 74%, and the mutant group was 67%. The local control rates in the wild type group, interestingly enough, was 85%, but 65% for the patients who had mutations there. You can see the distant metastasis-free survival. So what is the proportion of patients who are free of any disease within the liver, intrahepatic, after 1 year? So 35%, which is quite low actually. You want this number to be higher because that means that they did not develop new metastasis. Extrahepatic metastasis, was a rate of 56% and 61%, for these patients. When we look at the TP53 mutants versus wild type, interestingly enough, the overall survival rate was low here, 52%, and the local control rate for the mutants with TP53 was also relatively low. You can see, things that were probably driving these outcomes was that these patients often, had very poor, distant metastasis-free survival inside the liver. So this means that 94% of them developed new liver metastasis within a year after radiation. 65% of them, had extrahepatic, so outside the liver metastasis. So there's only a 35% rate of distant metastasis-free survival for these mutants with TP53. Whenever we look at ARID1A, 69%, 72%, 30 and 59. So quite comparable to these IDH1 mutation carriers. When we look at the FGFR fusion patients or mutant patients, these are actually, some of the more promising numbers in terms of both local control and overall survival, 92% for each of those. Whereas the wild type for FGFR, was 69% and 75%. When we look at the intrahepatic, rates, you again see a very similar story as the others. It's quite common for these patients to develop new metastasis, whether inside the liver or outside the liver. And overall, these are the rates. So 73% 1 year survival following radiation in this particular, expanded group of patients who got ablative radiation. 81% local control, as I mentioned earlier. And again, like the intrahepatic and the extrahepatic, distant metastasis-free survival rates, were, things that I think indicate that there's much more that we need to do for our patients. So that's the results with the molecular profiling and, what radiation does in the context of those different subgroups. Certainly limited patient numbers, and we need to look at the combinations of these different things with regards to, TP53 with, say, FGFR or, TP53 with IDH1. We haven't been able to discern those things quite yet because of the numbers of patients. But where we're going with this is to start to reach out to other major academic institutions. We're leading a project where we're trying to collect all this data from other major institutions, and this is with the help of the Cholangiocarcinoma Foundation and ICRN, the International Cholangiocarcinoma Research Network. They have helped us to establish collaborations with other institutions, largely within the US, but also internationally, to try to collect more data so that we can start to begin to look for signals that suggest that there's either sensitivity to radiation or resistance, and that will help us to design new approaches for our patients in the future. And particularly in specific mutation groups, TP53 in particular, where there's kind of the worst numbers that we saw, we need to think about new approaches and how we can overcome the resistance that we're observing there. Certainly, as we go forward, the targeted therapies for FGFR, for IDH1, and immunotherapy, those are all things that we need to begin to look at in combination with radiation, especially these higher doses of radiation, so that we can start to achieve the local control within the liver that we need, but also address the distant metastasis, the spread of the disease to either within the liver or outside the liver, and improve outcomes, with that type of combination, and especially whenever we think about these molecular subtypes. Adapting radiation therapy is another direction that we're very interested in going, because as I showed you, we can achieve, local control with these kind of uniform radiation treatments. But what if we had a early response metric, after say the first 3 or 5 fractions of radiation, suggesting, say, in the patient with a TP53 mutation, that the patient's not responding adequately. that would indicate to us that we need to dial up the radiation dose, since that justifies, the need to, to take a little bit more risk in that situation, because we ultimately want to achieve the best outcome for our patients. And so adapting the radiation therapy is something that's under investigation as we speak, and so we're very excited about. And this is just one of the trials that we're involved with. We're using functional imaging, to look at the normal liver and be able to calculate the radiation dose to that functional liver volume, and then also using advanced imaging as well as radiation delivery techniques to make sure that we spare as much healthy liver from radiation exposure, and then also personalize this radiation for the given tumor. There's a number of cohorts in this particular study, but we're actually finishing this up and building on this, the results of this that we've plan to publish in the near future. So just to summarize, ablative radiation doses can substantially prolong the survival for patients with liver cancers, especially intrahepatic cholangiocarcinoma. We've observed whenever we give lower doses of radiation or just chemotherapy alone, that unfortunately many patients with unresectable disease will die of tumor-related liver failure. And so a multimodality approach to achieve safe and effective radiation therapy, is how we would hope to improve survival, by getting better control of the liver situation in that primary disease. This is what we see, is translating to prolonged survival times for our patients. But there's still a ways to go. Again, we're seeing patients develop metastasis outside the liver as well as within the liver after the radiation. And so we need more effective systemic therapies and targeted therapies to combine with this radiation approach. The key technologies that drive this are highly conformal therapy, whether with X-rays, photons, IMRT, stereotactic radiation, or protons. The image guidance as well as the motion management are other critical pieces. We're seeing that molecular characterization as well as personalization of cholangiocarcinoma, both intrahepatic as well as extrahepatic, it is the way that we want to go for the future. And we have multiple prospective trials that are ongoing to help us to direct this, for patients, now and going forward. There's a number of people that I have to thank, to get to this point, in presenting all this information to you. First of all, the Cholangiocarcinoma Foundation and the ICRN, the Radonc working group was quite extensive, so I didn't have enough space on this slide to show all the names, but we're working with a really motivated and very academically and intelligent group of individuals. So it's been a great pleasure working with them and trying to build out the results that I just showed you with the molecular characterization in particular. MD Anderson has a wonderful multidisciplinary group. Dr. Java has been a great mentor of mine. And our laboratory, a number of people have contributed over the years to our endeavors, especially with regards to cholangiocarcinoma. So just want to thank them for all their efforts. And we've been very fortunate to have funding from multiple sources as well. So I want to thank them as well. So that concludes my presentation. I want to thank you again for taking time out of your day to listen to this presentation. I'll be very happy to try to answer some questions.
Wonderful. Thank you. That was great. We do have some questions, so I'm going to get right to them. Has radiation therapy shown any benefit or improvement in reducing the occurrence of blockages in bile ducts due to tumor ingrowth in the metal stents?
Yeah, that is a very good question. And it depends on the clinical situation and how well we can relieve the blockage prior to doing the radiation. So sometimes we have to go in either from the inside, through the common bile duct, or from the outside, using percutaneous drains. Once we're in good control of that situation clinically, and so the bilirubin is at least trending downward, we have given radiation in that situation and have seen responses and durable local control, meaning that the tumor doesn't continue to grow in that vicinity. So there's a number of steps that we have to take prior to delivering the radiation, though.
Okay. What is the difference between this and PBC?
TBC.
P as in Paul, BC. I'm not sure. Not sure what that is.
Yeah. Is that? Oh, primary biliary cirrhosis, maybe.
Maybe.
Yeah, so I'm not sure what this
I'm
is
not sure
referring
either.
to either. Yeah, Allison, I'm happy to if you want to contact Melinda or somebody else from the Cholangiocarcinoma Foundation, if you want to clarify your question a little bit, I'm happy to answer it offline.
Yeah, and that was a question that came in from Facebook Live. So I'm wondering if these treatments can be performed if there are lymph nodes involved in periceliac and if there's bile duct dilation.
Yes, Julie, thanks for your question. The answer is yes. We have treated patients with both, large liver tumors as well as lymph nodes in those areas in the middle of the abdomen and, leading up to the liver. So those are often encompassed in our radiation field. So yes.
Would you please discuss the use of radiation to change a non-resectable tumor to one that can be removed?
It's a good question. We often do not do radiation prior to surgery, especially for intrahepatic cholangiocarcinoma, largely because one of the other side effects of the radiation is scarring or fibrosis. So it makes it more difficult for a surgeon to remove the tumor after radiation therapy in the liver. Now, we are looking at this in the context of transplants. So this is a collaboration with our transplant team at Houston Methodist as well as other centers. And the situation there is trying to achieve local control of the tumor and making sure that the patient's disease doesn't spread elsewhere while the patient's on the transplant list. So we have actually successfully done this for several patients now. And are evaluating that as we speak. So I, for one, have actually had a couple of patients who have successfully gotten on to transplant after these high doses of radiation. So yes, you can do that, and that is an outcome that we're excited about.
Okay. Some of these are long. I'm just making sure you hadn't already discussed them during your presentation. What would be the considerations in deciding what radiation options may be preferable for a patient who, since resection, has had periodic cholangitis episodes and for whom a recent 2-centimeter abscess is felt to have evolved due to a blockage from a documented small tumor recurrence? That's a big one.
Yeah. Let me make sure I understand the clinical situation fully. So, I mean, in general, whenever we see a patient with blockage like this, we often have to first alleviate that blockage. If it's because of the tumor, we have to get a stent in or some sort of drain to make sure that the bile is getting out somehow. If it's an abscess, as in this situation, like a 2-centimeter abscess, we either have to see that resolved or treated, or just make sure that it's no longer a problem before we start the radiation. But we have done radiation in each of these types of situations, and especially in the situation of periodic cholangitis that's thought to be due to tumor. That is a situation that we have seen some responses and benefit from the radiation.
Okay, so besides the liver, would you use radiation in tumors elsewhere in the body?
Absolutely, yeah. For patients with cholangiocarcinoma that's spread to other sites like the lungs or the bones, we do use radiation in those situations. If it's just a single nodule that's not responding to chemo or has responded to chemo, and we just want to kind of consolidate, as we call it. We can deliver really high doses using very similar techniques as I talked about today for the primary liver tumor. There's also a palliative benefit for radiation in some situations. Like if you have a really painful bone metastasis, we've seen responses there also in pain relief from external beam radiation. So yes, you can use this in different contexts, for a given situation.
Would you ever use radiation in lymph nodes alone if that was the only presence of cancer?
We have done that also, yes. The same sort of principle about achieving local control for some of these lymph nodes applies. These can often be in places that our previous question asked about, like along the blood vessels that lead up to the liver, those critical highways, the portal vein, the common bile ducts reside right along there. And we have seen situations where those lymph nodes just continue to grow and either mechanically obstruct those tubes or they directly invade into them. And so that can lead to liver failure as well, or major complications. The same thing can happen with the surrounding bowel. Those lymph nodes can invade right into those things. So these are malignant cancerous processes. And so achieving local control whenever you anticipate that those lymph nodes are going to become a problem for the patient, one way or the other, vascular, biliary, or bowel, that's where achieving local control can also be beneficial.
That is wonderful. Thank you so much for answering all the questions. I will try to capture the ones we didn't get to and see if we can maybe get those off to you, Dr. Koay, if you have time. But I don't want to keep you. We've reached our hour. We appreciate you so much for being here and doing the presentation for us. And thank you, everyone, for your questions. And I hope you all have a wonderful day.
Thank you.
Thank you so much.
Pleasure.